Hi there, friends and colleagues. It's Sam Collins, your coding and billing expert for Chiropractic, the H.J. Ross Company, and ChiroSecure. We're always here to make sure your office continues to grow and thrive, and let's do it without any risk and make sure your practice is a bit better. Let's talk about what you're all experiencing, because I get this question quite a bit. How do I deal with pre-authorizations where they never pre-authorize more than a few visits or never let me get what I really think the patient needs to get better? What is it that the carrier is looking for? Have you ever understood what they look at so we can make sure to provide them what they're needing? I won't say you should compromise what you do, but make sure you're adding the things that they need in order to give your care plan the go ahead. So let's go to the slides. Let's talk about pre-authorization with all of these carriers, and you're going to see this all over. I'm showing some examples here of different ones, the forms that they have, as well as how many visits, but you've all experienced it, whether it's ASH, Blue Cross Blue Shield, Optum, and so forth. What is it they're requiring for pre-authorization? So let's define that. Pre-authorization means a decision by the health insurance to decide whether the treatment plan or care is medically necessary. Now, you hear lots of terms to kind of bandy about with this. That'll be like it's pre-authorization, prior approval, pre-certification. Doesn't matter. All really means the same thing. So we have to start to focus on what is it that they are looking for? How do they determine the need for care? Because I know from our standpoint, and I get this question quite a bit, how come they always cut me off at 5 or never give me more than 6? Well, let's get into the carrier's mindset of why. And I'm always going to say, let's turn that on ourselves and look at, does what we're providing dictate the level of care we want? So we have to look at what they think, though, and we do know this. They state things of this nature, and I'm taking this directly from American Specialty Health. And it says, care is focused on rapid attainment of defined objective functional outcome. Now, I would certainly agree with that. We want the patients to get well as quickly as we can and effectively. Obviously, that's the end of the day what we're expecting. However, we have to make sure what are they looking at and what guidelines, because they're going to use some pretty strict guidelines, American College of Occupational Environmental Medicine, maybe the official disability guidelines or other evidence-based guidelines. So you got to be familiar with what those are looking at and when you can go beyond. Because remember, when you see an average, average means everything is perfect. Like an average person with an ankle sprain might only need care for a couple of weeks at best, maybe even no care. But what about when there's other complicating factors or greater severity? How do they know that if we're still just using that same diagnosis for sprain? So when it comes to medical necessity, I want you to see, what does a carrier look for? And these are going to be the 9 things that carriers place importance on that you should too when you're making that pre-authorization request. The number one thing they look at is diagnosis. And we must be careful to make sure we're not having rudimentary diagnosis, because those are going to be always difficult to get a lot of care from because they're simple diagnosis. So think of it. Does your diagnosis fit the care plan? You're requesting a certain amount of visits. Does that diagnosis equal? If you think the patient needs 30 visits, does the diagnosis equal that? So let's look at some diagnosis from this standpoint. Think of yourself in a way when you're diagnosing a patient, you're an artist. And I want you to think of, are you painting Monets or Rembrandts? Monets are beautiful paintings. However, if I asked you who that woman was in the picture, you would have to say, I don't know, I can't identify her. But the one on the right, being a Rembrandt, is more detailed. And so keep in mind, if you've ever seen this joke, a lot of teenagers often use, they'll say someone is a Monet. And you might think, what do they mean by that? You know what they mean? That the person is good looking from a distance, because when you get close, it's not so good. And I want you to think of kind of diagnosis that way. From a long distance, back pain is fine, but does it really dictate a care plan that's going to equal 25 visits? Of course not. So I want you to start thinking of, how are you diagnosing? Am I doing Monets that are pain and symptoms? They're not incorrect. They're just not very detailed. Like if I said cervicalgia, great, my neck hurts. Quite frankly, my 9-year-old grandson could make that code, if you will, because someone could say their neck hurts. Oh, describe it. So in other words, this is the description of a condition. Even subluxation, while we're chiropractors, does subluxation on its own necessarily dictate a large treatment plan? Technically, no. Philosophically, I get it, but technically, no. So we have to be a little bit more than just that. Now, if you're going for a few visits, this is fine. But what can cause pain? Think of the reason. If it's just a headache, okay. But what about something like cervical radiculopathy? Or how about cervical brachial syndrome? Neck sprains, neck strains. How about neck myalgia or myalgia of the neck? How about enthesopathies, the so-called tendonitis codes, muscle spasm, fibromyalgia, spondylolisthesis, disc issues? Notice all of these things can cause pain. But what we all agree, someone with radiculopathy would need more care. So be very careful. Pain is not your friend when it comes to necessity. So if you're coding one of these things you see on the right, pain is a throwaway. It doesn't help us because it doesn't dictate anything we don't already know. If I told you I have myalgia or cervical radiculopathy, does it help if I say, oh, and it also hurts? Not really. So they're looking at severity of diagnosis. So start thinking along the lines of this. If you're thinking your patient needs 20, 30, 40 visits, that's certainly possible. Does the diagnosis you make someone who sees that immediately go, oh my goodness, yes, they're going to need that much? Now, grant you, they're going to err more cautiously than we might, but you've got to think the same way. Well, how about the last one I point out, just headaches? Would we all agree someone with a migraine is going to be different than someone with, when we say just unspecified headache? How about this instead? Cervicogenic, coming from the neck. So give me a code that better fits. The next part of medical necessity is, and they pay a lot of attention to this, you may not think so, but that's why they always ask those things about what is the past medical history? What's going on? Is it traumatic? Is it repetitive? Is it acute, subacute, chronic? How about exacerbations? How about if it's recurrent? Think of all these things make a difference. This is the narrative. That's why they have us write a short report. Some of you may think, oh, they don't pay attention to that. They do, but they don't give you a lot of room on the form. So sometimes you have to put a little bit more. Remember, that diagnosis doesn't tell us all of that information. So if there's something complicating it, we have to make sure that it's there. And by complications, please make sure you're identifying comorbid factors. Every carrier that does pre-authorization will actually pay attention to complications and comorbidities. These are underlying health conditions that may not be part of the problem, but will complicate recovery. And if you don't report it, it doesn't exist. I mean, think of how many times you've taken an x-ray of someone. And if you code neck pain, but don't highlight that there's disc degeneration or decreased joint space with, saying a spondylosis or curvature changes, that means no one knows it, so it has no effect. So how about coding things like that? How about acquired kyphosis? Happens all the time for most people. How about scoliosis? Or spondylosis, just meaning arthritis changes. I mean, how often do you see that even as someone as young as 30 years old? Start to make sure they see a complete picture. What am I painting here? Would we all agree if someone has a reverse cervical curvature with lipping, spurring, and eburnation, with even a neck strain or even pain, if you will, would that person require more if all you knew about it that it was painful? Well, what's the next factor for medical necessity? Your physical exam findings. And this is something important that you have to look at because they're focusing on it too. That's why they're requesting that you send them information. So it means everything you do, range of motion, palpatory findings, orthopedic testing, or neurologic testing, you must quantify these. Please don't tell me the patient feels pain. I get that. How severe? Where is the locality of it? What does it inhibit them from doing? How does it affect their range of motion? Because those are measured factors. And remember, pain level by itself doesn't mean a lot in the way that we typically do it. If you have a patient tell you their pain is a 5, what does that really mean compared to when it's an 8? So we need some better way of quantifying that so that way when they're looking at the care plan and looking at the outcomes, they can see that the care plan is making the patient better. Understand this. What if you say there is taut and tender fibers? That is an accurate statement. What does it tell me? It's taut and tender. Now, that could be a very little bit of taut and tender or a lot. That's like saying if you have money. If you have $1 in your pocket, you can say you have money, but that's a big difference compared to if you had $10,000. So I want a little bit more here so that someone can see the changes. If I put you on a diet, I have to do some way of quantifying how you're changing, whether it's by scale weight or measuring with a tape. What's the other factor we have to think of? This is the big one for them. Functional limitations by using validated outcome. Every single plan like here does this. You've got to get used to doing these because if you do, it shows your care. Here's what I will tell you. Chiropractic works well. It doesn't always show up in our notes the way we want because we don't have that tangible evidence. So I want to make sure you're doing something like this. Take a look at this pain scale compared to the one that most people have been using. The one that we most use is just all over the place. When it's at its worst, it's a 10. No, a 10 means you can't function. And one person's is different from the others. So we want something more tangible. Notice what number 5 says here. It says interrupt some activities. So it's not about how much it hurts, but what it's doing compared to what if it's an 8, I can almost do nothing, a little bit. But a 7, I can do it, but it's preventing me from most of it or a little bit more. So notice this is not as much a pain scale, is it, as a functional scale. And since insurance companies look at function as a result of care, let's start putting a pain scale together that does this. Now, this is the one put out by Department of Defense and Veterans, but there's no reason you shouldn't use that for everyone. And in fact, what makes this a really good form is two-sided. Notice there's 4 questions on the back side of it that says, hey, how has your activities been in the last 24 hours? But notice also sleep, mood, and stress. So looking at the person more holistically. So how about having this day-to-day where the patient comes in, and I won't even say fill this out. You know what I would do? I would take this type of page, blow it up to a poster, and put it on the wall to your office. Now you may be thinking, well, Sam, great, but where do I get that? Well, do this. I literally need you to take your phone right now. Get your phone. I'll give you a second. When you get your phone, open up the camera, bring it up to the screen. And when you bring it up to the screen, you can hit a text message and it'll say to you, hello, we're happy to send you the pain scale. In other words, our gift to you from ChiroSecure and H.J. Ross is this form. You then will send us a text to, or by the way, if your phone doesn't do it, don't panic. Just text to 714-2804-4697 because it's important that you make sure your care is necessary. We want to make sure you have the tools. So please make sure to get a copy. And here's what I do. You're going to get an email or a text of this actual form in a nice, clean format that you can print, and it's not a copy of a copy, as well as you can blow it up any size you want. Because I know your care works, but can I always evidence that by your chart notes and your outcomes? So let's use that, because certainly medical necessity is going to go beyond what we're mostly typically thinking of. Well, the patient feels better. Give me a function. The next factor is, you know what they pay attention to? The goals. Well, if we're using outcomes, the goals are going to be a little bit more evidenced. But think of something that is, and this is, by the way, taken directly from a carrier, functionally based, realistic, measurable, and evidence-based. So notice everything is function and measure. So just start measuring, start quantifying. I would argue that if your notes are slightly weak as far as the format, if you have good outcome assessments, it's always your savior, because at the end of the day, what are they really paying you to do? Make the patient better, that they're not just at a plateau, and it's maintenance, if you will. So think along the lines of functions and ADLs. If a patient says what their pain is, oh, good, tell me what you can't do, because that's what we write in this pre-authorization. We can show that, hey, that patient initially came in, they couldn't tie their shoes and bend down and do that. Now they can tie their shoes, but of course they can't sit for an extended time still, or they can't reach and fully touch their toes except in a sitting position. Do you notice the difference here? It's not about how much it hurts, but how it affects their movement and their activities of daily living. The final factor is, how do you dictate this for your actual care plan? And I want you to see a couple things here that it's important to note. This is not Sam's idea. I'm taking this directly from the carrier. This is from the Cigna Clinical Policy Bulletin. And what it says is this: the provider should attempt to integrate some form of active care as early as possible. Continued use of passive care modalities may lead to patient dependency and should be avoided. In other words, what are they actually saying here? We want you to do more active care of the patient than passive. Everyone sees that, whether it's home care, but how about in the office? Because notice it says passive modalities are most effective during the acute phase, since they are typically directed at reducing pain. Well, pain is only part of this. We've got to get function. So quite frankly, what they're kind of saying is, stop using the passive, cheap care, use the more extensive and expensive active care, because it's better for the patient. Every guideline says it. In fact, take a look at one more. This is from the NIH. It says it has been recommended that passive modalities not be employed except when necessary to facilitate participation in active treatment. Treatment of chronic non-cancer pain is that are the results from traditional passive modalities, it says, are disheartening. Perhaps this may be due to the propensity of patients just seeking out the relief. It doesn't really make them better. Notice this all goes back to active care. What has chiropractic always done? Focus on the active. So give me something about where's that diagnosis lead me to? What are the complicating factors? What's going to make it take longer? I mean, think of all those things. Person's overweight, deconditioned, they're diabetic. There's a lot of things. Maybe you're not even treating it, but they affect the recovery. If you think it's affecting the outcome, if you don't write it down, it doesn't exist. Then from there, focus on a care plan that focuses on function and active care more than passive. Realize passive care is necessary, but realize that should facilitate the active rehab part of it. If you do those things, you should do much better at getting care, because now you're dictating. Because I'm not saying the reviewer necessarily doesn't want to give you care, but they can only give it if you hit the points that they require. So let's start realizing if those are the things they're emphasizing, we have to make sure we're reporting them, whether or not those are ones you may always want to do, but they're the ones they require. And since they're paying the bill, I want to make sure we do that. Because what's more frustrating than a person that needs care, that you work on it and they don't get it? Now, this doesn't mean this is going to open every door, but this is going to make a big, big difference. Really start to be a better student of coding and think of functional outcomes. If you do that, you're going to resolve a lot of the issues that most people get. Realize a lot of this stuff is already available to you. Go to our website, H.J. Ross Company. We have a news section that updates things like Medicare rates increasing. How about the coding changes? What's better codes? Have you ever done a program that really talks about coding beyond the simple, oh, here's a list? Let's do something more than that. We offer a service where I can become part of your team. Join our network. I'm here to help you. I want to make sure you have the right things. Let me help you write that darn thing. Let me show you what works and what doesn't work. And so I'm going to say to all of you, thank you very much. It's really important for me to be part of what you do because I love this practice of chiropractic. My dad was a chiropractor, as am I, and I want to make sure our practice continues to grow and we get more access to people because we've got to stop the opioid crisis. Chiropractic is part of that. Thank you, everyone.